Right, well, let's get started. I'm Nancy Ann Deparle. I'm the former Deputy Chief of Staff for Policy to President Obama. And before that, I ran the Centers for Medicare and Medicaid Services in the Clinton administration back in the late 90s, early 2000, when critical access hospitals were first established. And I'm thrilled to be here today to speak about a topic that's very important to me and to introduce two important champions of both behavioral health and rural America. And I'm particularly pleased to be here with the National Rural Health Association and would like to thank them for their leadership and their tireless advocacy on behalf of rural America and rural health issues. I've worked with the National Rural Health Association through all of my different jobs in Washington, and before that when I was in Tennessee, and they just provide really vital leadership for us here in Washington. The need for behavioral health services in rural areas is dire. Suicide rates were 50% higher in rural than in urban centers before the pandemic hit. Yet 80% of rural counties don't have a psychiatrist. Critical access hospitals fill an important void in delivering healthcare services in rural areas. Giving critical access hospitals the flexibility to deliver behavioral health services through telehealth allows them to reach more patients. And let's be honest, in many cases, critical access hospitals and the services that they can provide are the only mental health resource available to seniors in these areas of our country. So I'm thrilled to be here today to support the Rural Behavioral Health Access Act that will allow critical access hospitals the ability to do this permanently. They had some flexibility during the pandemic. We need to make sure that it's continued so that these seniors can continue to be served. I'd like to welcome two champions, as I said, of behavioral health and of rural America. The Honorable Representative Dan Kildee from Michigan will speak about this legislation to help critical access hospitals. Congressman Kildee has been a longtime advocate for behavioral health since his days working at the Whaley Center, a residential treatment center for children who have experienced trauma and abuse in Flint, Michigan. He continues that work now, serving Michigan's 5th District as a member of the Ways and Means Committee. And following Representative Kildee, we'll hear from the Honorable Brad Wenstrup, who is serving as the Republican lead on this effort. And as you know, Representative Wenstrup is a doctor of podiatric medicine, co-chair of the Doctors Caucus in the House, and an Iraq War veteran. And he's a leader for patient-centered healthcare reforms in Congress. He's the representative from Ohio's 2nd District, continues to see patients at Walter Reed National Military Medical Center in Bethesda, and he's also co-led the Ways and Means Task Force on Rural and Underserved Communities. So with that, I'm going to welcome Congressman Kildee to speak about the Rural Behavioral Health Access Act. Thank you.
Well, thank you, Nancy, and thanks to everybody for being with us today. Special thanks to the National Rural Health Association, as well as the Alliance for Connected Care for hosting this. It's also great to see Rose Goick Sadler, who's working on the front lines in my own district up in Standish, Michigan. I'm glad she's here to participate in the event. And I'm especially happy to introduce the Rural Behavioral Health Access Act with my colleague and fellow Ways and Means Committee member, Congressman Brad Wenstrup. Brad and I came to Congress together back in 2012. He's a good guy. We don't let our regular disagreements over some big issues, we don't let those disagreements cancel our areas of agreement, and this is one of those. I think it's also noteworthy that Brad is exactly 55 days older than me, and I'm sure he appreciates me pointing that out, even though you can't tell by looking at us. This is really, it's on a serious note, this is important legislation, allowing critical access hospitals, including Ascension Standish Hospital, which is in my district, to continue the important work delivering behavioral health services virtually after this pandemic. Coronavirus does not only attack physical health, it's impacting mental health, and we're all seeing that every day. Behavioral health needs have definitely increased across the country, especially in rural and underserved communities since the beginning of this pandemic. Many of our fellow Americans are facing grief with losses of loved ones. shock due to impacts on their employment status, isolation, which is a particularly difficult issue, changing and challenging family dynamics, and of course, uncertainty about the future, which creates an awful lot of stress. So I'm hopeful, obviously, that the end of this pandemic is in sight with a third safe and effective vaccine approved by the FDA and with vaccine distribution steadily ramping up. But we know that new or delayed behavioral health needs won't just disappear when this pandemic is over. Despite having a similar need for services, though, the research has shown that people who live in rural areas, and I have a pretty expansive rural area in my district, we know that people that live in those areas have less access to behavioral health care services than people who live in more densely populated areas. COVID-19 has exacerbated those behavioral health challenges and is increasing demand on already strained resources. So our bill, the bill that Brad and I have been working on, will address those unique challenges that rural communities face in accessing behavioral health by allowing critical access hospitals the flexibility that they need to continue providing these important services virtually. Just a couple of weeks ago, I was on a call with hospital leaders in Michigan, and we talked about this. We talked about the growing problem of behavioral health access in my home state of Michigan. It was a problem before the pandemic, and the pandemic has just simply highlighted the need to address this problem for the future. It's a complicated problem requiring a multifaceted solution, but I believe that our bill can be a small part of that solution by making mental health care more accessible and more available to patients. So finally, while the coronavirus pandemic has resulted in serious challenges for our communities, it's also provided us with some new opportunities for patients and health providers to use telehealth technologies in ways that our country has not used before. I believe that our legislation is an important element in this larger conversation about how to modernize our virtual care laws. Again, I thank you all for joining us. I look forward to working together to increase access to behavioral health in our country. And I'm particularly proud and pleased that I'm working with my friend, Brad Wenstrup, whose service to our country goes well beyond his time in Congress. And I've always been proud to call him a friend. So thank you all. I appreciate you allowing me to be a part of this.
My turn.
Yes, Congressman Wenstrup.
Yeah, thank you. Thank you, Dan. Appreciate that. And I think one of the things that really works for Dan and I, we have a couple of policy practices that we both keep in mind, and it's the use of sarcasm and personal barbs towards each other. And every once in a while, we do actually compliment each other. We do get along really well, and that's why it's exciting to be here to do this with Dan. And I want to thank all the participants for leading the way on such an important issue for my district in particular. And so working with Representative Kildee, my friend, on the Rural Behavioral Health Access Act, it's important because it'll allow critical access hospitals to continue to deliver mental health services virtually, even after the pandemic. It was mentioned that I sit on the Rural and Underserved Healthcare Task Force on Ways and Means. It's bipartisan. And these are the types of issues that we are addressing, and telehealth has become huge for rural healthcare in general. And we will figure out the best ways to move forward with continuing to use that so that people have access to care. And that's what we're trying to do. And I would like to take a moment to recognize Mr. Berg, who was on this call, and he's helping to expand access to behavioral health care in my district, specifically in Adams County, Ohio. And it's greatly appreciated, all the work that he does, and on this issue as well. Behavioral health has long been a priority of mine with the opioid epidemic and the unique challenges that we found with that, obviously, and especially amongst my rural constituents. And, my undergrad degree is in psychology, so it's always there in the back of my mind. As a doctor, I'm especially concerned about the impact, for example, that the virus had and the necessary isolation and what that has done on our mental status. And I think all of us can relate to that to some degree, and especially those that are vulnerable and subject to mental illness, it just can only exacerbate it. So it's threatened our health, but we've had millions of Americans not able to see their families. They've lost their jobs. They've been forced to shutter their business. So I'm really proud to sponsor this bill with Representative Kildee. It's going to help my constituents immensely. Americans across the country are going to receive mental health care that they need that maybe we're not able to get otherwise. And giving Medicare the ability to deliver mental health care through telehealth will allow rural communities to do just that, to reach out to many more people. One of the things that I said when the pandemic started on earlier in its early phases a year ago is, yeah, it's important to physically distance. That was, I think, the key. We said socially distance, and we really should have kept socializing. And that was important. There's many ways that we could to socialize with one another through it's like a venue like we're doing today, or on the phone, or whatever we can do and do it safely, I think was important to us. So, this is an opportunity for us to do something positive and over time compare numbers and, look at the number of visits we have, the usage that it gets, and post-COVID, especially what kind of numbers are we having, and I think it's going to be especially important that we may be able to look at some potentially avoidable adverse events that maybe didn't take place. It's always hard to measure what you prevent, but adverse events that didn't take place, and hopefully we'll see numbers like that drop if we can get this through and implement it the way that I think it can be most effective. So thanks to everyone who's worked so hard on this bill, for all your work towards helping deliver high quality mental health care for rural communities. It's greatly needed, and we'll keep driving home. So thanks everybody for being here today.
Well, thank you. Go ahead, Nancy Ann, are you? Okay, thank you, Representatives Wenstrup and Kildee, for your great work in sponsoring this legislation in Congress and to make it possible for our rural hospitals to be able to do the best that they can in meeting the needs of their community. I'm Brock Slabach, Senior Vice President at the National Rural Health Association. I'm joining you today on this call from Leawood, Kansas, and I am pleased to be able to share in this time of talking about this important project of continuing the learning that we've achieved through the pandemic into a post-pandemic world. And yes, I'm very thankful that we're able to look a little bit more ahead to see that future at this point. I'm watching with great interest the large container ship, over 200 million tons, that's stuck in the Suez Canal in Egypt right now. And it struck me last night when I was looking at that big ship sitting there blocking all the traffic that's coming behind it, that we're like that in our rural healthcare system with telehealth after the pandemic. We've been flowing with telehealth services in our rural communities, and we're going to hit a point where we could be just as stuck in rural communities with telehealth at the end of the public health emergency that we're in, that the Suez Canal is experiencing with that large ship being stuck there now. So I think we need to really start to concentrate on our efforts as a community in the critical access hospital space to be able to enunciate, one, the need, and two, get the legislation that's going to be able to give us the craft, the ability to craft the response that we need for our communities. So before the pandemic began in March of last year, it seems just like yesterday in some ways, and in other ways, it seems like it's like an eternity ago. We were looking at restrictions on telehealth. So before the pandemic, we were running less than 1% of all billed services in a telehealth context, less than 1%. Then once the pandemic began and CMS asked all providers, including those that are on this call today, to cease all elective and non-emergent services. Our hallways emptied out. The clinics became barren of any patients. And as a result, we had the hemorrhaging of cash from our operations because of the loss of patients and the revenues generated because of that. It was very quick that CMS and the Congress stepped in, and they began to allow critical access hospitals, rural health clinics, and federally qualified health centers to be able to use telehealth as distant site providers. This enabled rural health clinics and federally qualified health centers and CAHs to be able to bill for services from their facilities with the patients being in their home, what we know of as the originating site. And this is an important feature because after the pandemic began and we ramped up our telehealth services, 70 to 80% of all billed claims from our clinic and ambulatory spaces in our country were billed using telehealth claims for the services provided. Because that was the only way we had to connect with our patients. It was the only way that people sitting at home worried about coming to the emergency room, worried that they would catch the virus if they entered into our spaces. They were storing up healthcare and not seeking service. So this provided them the outlet for that ability to come and seek those services. Now that we've ended those cessation of services in terms of elective and non-emergent services, in other words, we've reopened, our facilities are now seeing patients in their clinics and our hospitals are seeing patients in the hospital. We've equilibrated back to about 12 to 15% roughly of all claims being in a telehealth environment. But you think about the transition, the disruption that occurred to get from less than 1% all the way to 12 to 15% of our revenues being generated out of this one element of service. Now think about taking that out of our operations at the end of the pandemic because we go back to the way it was before. And I don't think that's a reality that any of us want. And I think that you all on this call today, working with Representatives Wenstrup and Kildee and those in Washington that are working to make this happen, we need to get legislation to be able to move all of these issues forward. And now focusing on behavioral health, making sure that that's part of the package that enables critical access hospitals to meet the needs of their communities. And that's ultimately what we're here to do this afternoon. The other element that I want to make crystal clear to everybody, rural healthcare is in a state, and is a very fragile state at this point. 46% of rural hospitals are operating at a negative margin nationwide. We have 135, 136 that have closed since 2010. And we need to be doing everything we can to make sure that they can remain vital to their communities, keeping local services available to the communities that are being served. And so that is another reason why this is so important, is to keep the facilities in operation, to keep their doors open, and to keep them to being able to meet the needs of their communities. So when I look at the future, I see the fact that we billed 125 million telehealth visits total in the United States in 2020. Think about that, 125 million. Stanford University now is greater than 35% of their revenues in their clinics are generated from telehealth services. And the estimated number of people that are going to be using telehealth in the future is skyrocketing. In fact, I attended a session earlier this week where Dr. John Burroughs predicted that in 2031, which is 10 years from now, most hospitals' revenues will look like this: 5% inpatient, 15% ambulatory, and 80% virtual. Now that is an amazing number. Now, even if we don't even get near that number in terms of services, in terms of percentage, think about the fact that if critical access hospitals, rural health clinics, and FQHCs aren't able to get into this environment of care, we're not going to be able to be serving any of our patients, and in a sense, we'll be going out of business. So it is my pleasure today to be joined with two of my colleagues who are going to help discuss this topic today in greater detail, and making sure that we are covering all the bases. And I want to, at this point, also encourage you in the chat, in the Q&A section on your control panel on your Zoom screen, to chat in questions. The folks, Chris and others, will be watching those questions come in and helping me make sure that those are addressed through the period of our conversation. So at this point, I want to introduce our two guests today. One is Rose Goick Sadler. Rose, as the congressman said, is from Standish, Michigan. She's at Ascension, Standish, Michigan, there, a hospital there. And they've done some really remarkable things in their operations, and I'm sure she's going to tell us some of what those are in just a second. The other guest that we have today is Alan Bird, who is the administrator at the Adams County Regional Medical Center in Seaman, Ohio. And this is a critical access hospital in Southwest Ohio, and is an important offering to the community there in Adams County, Ohio. So I'm going to kick off the conversation and ask Rose, and then in turn, Alan, if you could just give us a brief description of your hospital and community, and maybe a little bit about your community health needs assessment and what some of the findings were that came from that in terms of your facility. Rose?
Well, thank you. I'm so appreciative to be able to speak here and represent rural health. Rural health has been my passion for years, and we just have to represent these people that are in such dire need. Our hospital is the only hospital within our community. It is approximately about 15,000 residents. And recently we conducted a community needs assessment, and with that assessment have found that 30% of our residents are at or below poverty level. Only approximately 40% of our residents have a high school diploma. We are in the top 10% of the worst counties in Michigan for premature death. We're also in the top 10% of the worst counties in Michigan without access to care. So telebehavior or telehealth is vital in our community. The community also designated mental health and behavioral health as a priority for action. Throughout the pandemic, telehealth has revolutionized how we care for our patients and has actually increased access to care that they would not normally have. Our citizens in our communities have lost their jobs. They've had increased isolation due to shutdown. There has been an increased impact to their underlying health problems that were already present. The children within our schools, when they went to school, that was the only meal they would receive during their whole day. And then the school gets shut down. Ordinarily, our citizens, if they need to receive mental health services or additional skilled services, have to go across borders in other counties to receive those services. In this poor community, it becomes a choice of food, medication, or services they have to drive for. They don't have the financial funding to support this, so they go without. Our EDs are now seeing an increase in mental health issues, including substance use disorders and up to suicide. And I'm going to call out a special incident that happened here because it just kind of standardizes and level sets the dire need and vital need of telebehavior. Our community experienced a recent suicide of a 20-year-old man. He was well known in the community. So of course we have several people that are grieving and they reach out to the hospitals for help. Telehealth and telebehavior health was there to provide resources for them and for us to help them. During the pandemic, hospitals have been overcrowded. In some instances where we were unable to transfer, it was difficult to transfer to a tertiary center where services were needed. With telehealth, we were able to keep those persons within our communities and provide that service at the bedside. And then with the visitation restrictions and the shutdowns, our telehealth, we were able to stay connected with our communities. So this is one bill that I support and I am very passionate about, and I am glad others are too. Thank you.
Thank you, Rose. Alan, same question on your community's description and the community needs assessment that might inform you in some of your work.
Certainly. So Alan Bird, I'm a farm kid from rural Idaho, so I understand the market, the form that I'm in currently. I've been here for about 3 years. I love rural medicine. I love critical access hospitals, rural health clinics. I love working with the county commissioners and all of these communities that I've been in throughout my community. Just throughout the 20 years that I've been in healthcare, it just seems these rural hospitals, these rural communities, these rural health departments, it's hard to find doctors. It's hard to find nurses. There's probably 2,000, I'm probably a little bit wrong, but probably over 2,000 rural hospitals, 1,300 and plus critical access and a lot of PPS small hospitals. And probably 50% of them are on the verge of closing. And we've heard those statistics. Adams County is no different. Rose, each of the things Rose spoke to is bet on in our community as well. In Ohio, there's 88 counties. And I think Adams County, and we're trying to serve the Brown County community as well. All of those statistics are true for us in our community, and I'll speak to Adams County because that's where I live with my family, and I brought my family here to serve these people. Every other year, it seems like Adams County, or maybe some of the counties in southern Ohio, are the poorest, most impoverished. There's no jobs, and just on and on and on. And we were just barely, when I got here 3 years ago, we were losing about $50,000 to $80,000 per month when I arrived. We had about 4 days of cash on hand. And so it was all hands on deck to save a rural hospital in the edge of Appalachia. Amazing people. There's a large Amish population, about 126 Amish families in this area. They need health care. Our community needs health care. You could talk about a myriad of issues, not just behavioral health, but I was kind of asked to stay on task or stay on point today. But again, I love rural medicine. I love the program for the outpatient geriatric site program that came out a few years ago. It's probably been out 15 plus years, whatever. A tremendous program because of the access to care. If probably 75% of the people that come to this hospital within this community, 75% are Medicare or Medicaid. We've had 2 coal-fired plants close. GE laid off a bunch of people because of the virus. So just that commercial insurance margin just keeps getting smaller. And I'm sure that holds true in Rose's community and probably a lot of the critical access people that may be listening today. So I think there's a clinical need. I also think there's a financial need for this program as well. I think both of those will keep these hospitals open. It's one of those, if you don't have a margin, you can't serve the population. But I know that during the pandemic, our revenues went down by probably 45% the first couple of months. It was devastating. We're grateful for what the federal government did and some of those, the PPP and just different things like that. So thank you for Congress and the president for doing things like that. We worked exclusively very quickly. We had to react quickly because there was no margin already. We worked heavily with the big health systems in the Cincinnati market. We did not have any personal protective equipment. Nobody had huge stockpiles. And so just these hospital systems and us, they came together, they helped these rural hospitals get a lot of that personal protective equipment. And we thought we were going to come out of the pandemic over several months, 6 to 9 months. We thought we were going to be incrementally if we lost 45%, we were going to be increasing until we maybe found some type of new pre-COVID or current COVID or post-COVID financials. We came out of it a little bit better. The people are now starting to come back. I think the vaccine's rolling out fairly well in our community. People are having a little bit more maybe aware of it, things like that. But on the behavioral health side, that program, that outpatient geriatric psych program, has been in this hospital for about 4 or 5 years. It wasn't as strong, 3 or 4 years ago. We got a good team together in that program now. And what was 2 or 3 people in the community benefiting from that was soon 10 people, and some people on the waiting list. But then instantly COVID hit. And everybody was trying to react. They no longer could come to the facilities. And a lot of these people, if you can imagine in Appalachia, in Adams County, some of the people I'm talking about, these are the most impoverished, humble people without guile that I've ever met. They would give anything to you and for you. And suddenly they were cut off from the access to the friends and families in those group sessions, those individual sessions with the psychiatrist. Just a tremendous program. And we were very grateful that during that period, the federal government reacted, and we were able to, and our counselors and our people were able to start reaching out through telephone calls. And another big problem we have, I don't want to leave out, is in Adams County, the internet stinks. Okay, it's just, we can talk about this program, and if it's video only, it's just not going to work in our community. The telephone side of this will be critical to the success moving forward. And the people in our community aren't getting wealthier, they're getting less impoverished or more impoverished. The telephone access will be critical to the success of this program. So again, I'm grateful. I appreciate the forum today. I'm an advocate for rural, not just this program, behavioral health, but all critical access in general. And any opportunity, and not that I'm inviting Rose, but man, Rose and we're probably ready to go to Washington, D.C. and fight for rural America, critical access, FQHCs, and rural health clinics. We're happy to be here, and we're happy to answer some questions.
Thank you, Alan. And I'm sure that that'll be nice detail for all of our listeners today to make sure that they continue this conversation in Congress. Representative Wenstrup.
Yeah, just real quickly want to thank Alan. I appreciated everything he had to say. It's, as I hear him talk, it's all intimate to me as well. And so I appreciate it. And the point about the internet is a huge point that we need to make sure that we include, because it's just the way it is right now. And not that we're not trying to change it and wish it were different, but I get that. And his passion is tremendous. And he talked about how he loves doing all this and all the people he loved working with, but he didn't mention his congressman. So I'm a little disappointed, but we'll manage that on our own. Thanks, Alan.
Thank you, Representative. I think that, yes, like broadband is now becoming one of the factors of disparities that we find in rural healthcare, and the implementation of those last mile services to individuals that need to connect to these telehealth services are going to be critical going forward. And keep in mind, this broadband is not only just to do telehealth services like clinic visits or group therapy within the space of behavioral health, but it's also patient home monitoring. And I think that's going to be a real growth area for the next decade or two, which indicates the statistics I said earlier. So we need to be looking at broadband build out to be able to connect all of those patient monitoring at home, and then coupled with seeing their care providers using telehealth. So yes, it's all of that. So Rose, obviously at the beginning of the pandemic last year, you had a decrease in all of your business due to the closure of your elective services. I presume you stood up your clinics to do telehealth visits then after that, once you were given the authority, or how did you deal with that in your facility?
Yes, we did. We used virtual care for a lot of our visits, for our physician visits, for our specialty care visits, but our geriatric psych, we have a geriatric psych outpatient unit. They were impacted by all of this COVID. And for geriatric patients, they were scared to death to even enter the parking lot.
Mhm.
And we were able to meet where they are in their home and actually had an increase in enrollment. It was easier for them because they also have comorbidities,
Right.
the difficulties with mobility, the difficulties with comorbidities, and it was a satisfier for those geriatric patients.
So obviously, once we end the pandemic, and right now it's set for the legislation of December 31st, for the rural health clinics and federally qualified health centers to be able to provide distance site services from those entities. Obviously, you'll want to continue those past the pandemic, and you would consider that to be extremely valuable to your community and to the services you offer.
Absolutely, absolutely, because they have difficulty with travel.
Yeah.
And that when we come out of this pandemic, it's not going to change the fact that we don't have some of these services within our community. Now we're talking about those people that have lost their job, they're aged, and they would still have to go across county lines to receive that care. So having the telebehavior or telehealth within our communities keeps our patients and our communities safe. It keeps them engaged with their healthcare versus going without.
Great. So Alan, what about you? You had the same experience, I presume, when you had to discontinue your elective services. How did you fare with all of that?
You know, in the beginning, I think for all of us, it was difficult. Everybody's trying to figure out how this was going to work. You know, the technology, then the different pairs, how that was going to work. Within I don't know, a couple of months, we thought we were smart. I think we did okay. Again, we didn't try to reinvent the wheel on anything. We were reaching out to a lot of our partners, seeing what they were doing. I actually talked to a nurse practitioner today in one of our clinics. Again, it's hard in some of these rural settings to find really, physicians that want to live in rural America. So these nurse practitioners and physician assistants just creates, or they fill a vital role out here. And this nurse practitioner just talking about, so these staffing in rural America, contact tracing, these clinics were almost shutting down because of the contact tracing, kids, schools, or just whatever. And this nurse practitioner, she said, Alan, I was at home, I was, COVID-19 positive, and through telehealth, I was still seeing my patients. Otherwise, that clinic would have been shut down in that rural community. So that ability for that nurse practitioner to reach out to her patients to meet their critical needs, that access to care, that worked really well. Even in that weird environment, she was afflicted with that virus, but she was still able to and willing to. And she talked about, even as she was serving those people in rural America, she said to some of her patients, I would have to tell them sometimes, give me a second, I'm trying to catch my breath, as she was trying to help them and prescribe things to them and whatnot. But, before the virus, rural America had all of these behavioral health, psychiatry, mental health, all these issues, and we just didn't have access, except on a limited basis. So for a period of time, the light was turned on, the resources were turned on, and it's like giving something to somebody and say, this is what it's like to have access to behavioral health resources. And then all of a sudden, what if that gets turned off?
Yeah.
What's going to happen to these people? We can serve who we can serve, but what about the people that don't know about those programs, don't have access to those programs, and maybe we don't have resources to educate them about those resources? I just think opening up video, telephone, our ability to communicate through radio, billboards, through our different clinics, through our health departments. We work a lot with, even in our prison, our county prison here, they have serious mental health issues. And they're trying to partner with the UC health system on providing that psychiatry and mental health and different things like that. So we face the same things Rose did. It sounds like we followed similar paths.
Thank you, Alan. And I think that obviously, as we look at rural health clinics and federally qualified health centers, that's one piece of this puzzle that was solved by Congress in the spring of last year by removing those barriers from becoming distant site status providers in those particular entities. Now moving on to critical access hospital, it's a bit more complicated. CMS thankfully enabled the ability for critical access hospitals to participate in this distant site status programming, and gave us the ability for those services to be billed, which we're very thankful for. But those allowances will end at the end of the public health emergency. So your critical access hospital, Rose, with your behavioral health services, what are some of the things you mentioned? Jerry Psych, and that's an important service. So how does that look in your facility? What are you doing in terms of the connection between your patients that you have at home with the staff that's able to take care of them in this environment?
So with the staff, they were able to connect with these patients either via phone or virtual care. But we also, with our critical access hospital, have a skilled nursing. And those are some other barriers I won't even get into. That's been quite a ride too. But with those residents or patients, there was a disconnect. Visitation was shut off. I cannot even tell you how valuable some of this telehealth has been with those residents. They were able to connect with their families. They were able to connect with services in the community from their room because we couldn't take them out. Their families could not come in to visit. So they were able to virtually connect with those. With the Jerry Psych program, we could also use it within our skilled nursing unit, which was a huge, huge help because you have dementia and you have behavioral health issues that worsened with the isolation and the shutdown of the visitation. There was a lot more anxiety, a lot more traumatic events with the geriatric population. And then on the other hand, within our critical access hospital, we were able to keep patients within the hospital connecting with the specialized services at the tertiary communities. So it's just a huge vital need within our critical access hospitals to be able to reach out. Patients can stay within this community. Families can reach out to their loved ones, and we can keep them within our facilities versus traveling or transferring or, loss of care, loss of specialty. So it's extremely vital that we have these services.
Thank you, Rose. Alan, same question. What are you doing in your behavioral health space through the critical access hospital that you'd like to see continue?
Again, all of the video, all of the audio that has been provided, the ability for the staff members just to communicate well. And many times, a phone call is truly serving ministry. I'm not sure what word I want to use. A phone call to a Jerry Psych individual or a behavioral health, somebody that's struggling for whatever reason, mental health, maybe there's been a death in the family, maybe they're struggling with whatever. That phone call that day is the difference between how they feel, how their daily activities, just different things like that. If that's not continued and we have a hard time getting those people here, access to care, you talk about transportation, Rose talked about transportation, these people don't have the resources. Again, people in our community aren't getting wealthier, they're getting more impoverished, things like that. So we feel we have a moral obligation, we feel we have a duty to help those people and provide some of that technology. And a lot of in the city, maybe perhaps they have those resources, and we just want to have access to those same access to care. Many of these things are scarce and they're sacred, and we want to pull some of that out into rural America so that the people who are citizens who serve and who provide in these rural settings, we want to be able to take care of them. And even on and I'm going to shift, Brock, if it's okay, just to the financial side again.
Right.
50% of the critical access hospitals, I've been told, lose money almost every month. This behavioral health, this outpatient geriatric psych program, maybe expansion of some of these programs, because on a Medicare cost report, some of these programs, when Medicare takes square footage, if these programs aren't there, that's square footage that we can't be reimbursed on our cost report. And if we don't have reimbursement for some of these services, or we can't use that square footage in our cost report for these vital services, then if 50% of critical access hospitals are losing money, maybe it's going to be 60%. And I'm just afraid hundreds of small rural hospitals are going to close in the next few years. This program, what is perhaps provided in the bigger cities, that access to care, I don't think these small rural hospitals, the roses and eye of the country, we're not trying to be greedy.
No.
Just give us a little bit and we will serve these people and we'll take care of these people.
The way I like to say it is that we need to give you the tools to be able to serve your communities in the best way that possible. And so what this legislation really does is provide you the tools. And these tools are equivalent to what our providers or counterparts in urban areas are using and taking advantage of. I do want to point all of the attendees to the chat box where there are some links that have been posted to be able to actually take a look at the legislation itself. And then also, if you want to support the bill, you can do that at a link that's provided for you in the chat. There's a question, when will Congress vote on the proposed legislation to allow non-MSW, that's Master of Social Work, mental health therapists to see Medicare patients via telehealth or in person? And that gets into this workforce issue and recruiting those individuals to work in our facilities. That's another whole issue altogether. But how are you looking at workforce in your communities, particularly as it relates to behavioral health and meeting the requirements of the conditions of participation that Medicare applies to these programs? I'll start with you, Rose.
So as you know, it is extremely difficult in rural communities to obtain staff. When persons or people, professionals graduate, they kind of gravitate toward the bigger cities. The bigger cities have the funding, they have the, nightlife, they have whatever, there's more access to things. In rural communities, you have to be empowered, impassioned, and really, really want to be here. It is extremely difficult to recruit.
Alan, do you have any experiences on workforce that you care to share?
Yeah, it's, and when somebody on the call with us today, I just kind of ran through some of the questions. And one of the things they talked about was nurse practitioners that are psychiatric and mental health nurse practitioners. And we actually hired one recently. Again, in this area, could we afford to hire, usually it's family practice nurse practitioners, right? But we actually hired a psychiatric mental health nurse practitioner to start serving some of the needs of some of the patients in our 3 clinics. And during the pandemic, her reach expanded about 50 miles within Adams and Brown County for her ability to meet the need of these people. And we weren't sure how quickly that mental health nurse practitioner practice would grow. It was amazing. People were flooding as the word got out from all the different community agencies that we had hired a psychiatric and mental health nurse practitioner. People were just sending those to us. And so I guess the panel's question, or somebody's question was, how's this going to work in FQHCs or maybe a rural health clinic? Will a psychiatric or mental health nurse practitioner, is behavioral health, does that include that under the umbrella? And I don't have an answer to that, but that's a great question. But the ability to get mental health, the local judge came to me recently and he said, Alan, we need an inpatient behavioral health unit. And I just said, we don't have the money for it. And he said, we can't get people out of the jail. We can't get people out of the ER. And when you try to transfer these people, like Rose said, they may be there a week or 10 days. So we have nurses in the ER attending these people that we're not qualified to work with. So just again, it's difficult to answer your question. It's hard to get them out here. Anything that's going to help us meet the needs, because there's people depressed in the city. There's a lot of people depressed and have anxiety out in rural America, and we want to be able to take care of them.
It's a great point, Alan. Thank you. One listener wrote in to say that telebehavioral health in the VA system at the Veterans Administration yields a no-show rate of only about 2%, compared with 30 to 50% when a patient must travel to a brick and mortar office. I served on National Quality Forum's same-day access programming for veterans to be able to access care. And it has been really amazing to see how telehealth, how well patients pick that up. And this is an interesting statistic that I think is very compelling. So thanks for sharing that in terms of the no-show rates. We've been focusing on critical access hospitals today because of the unusual limitations on CAHs in order to provide these distant sites services. A lot of our urban counterparts that are in prospective payment system facilities and in fee-for-service clinics aren't really encumbered with some of these requirements and problems. So that's why Representatives Kildee and Wenstrup are authoring this proposal to be able to make sure, as I said, that those tools are going to be delivered to these provider types that are distinctly different from those that we find typically in our urban communities. Pat Scow, the president of the former past president of National Rural Health Association, writes in to say, excellent bill to support CAHs and helping them navigate delivery system change. Most importantly, the bill will help rural residents locally and finally have access. Thank you, Pat, for that comment. Yeah, I think that, so in the closing minutes that we have left in this program, Rose, you mentioned the suicide that you had in your community. What a sentinel event that must have been. It just probably rocked your community. Did that generate a lot of concern? You responded then as part of your recovery for that event. And I'm sure it's helped you kind of crystallize the need for this program.
Absolutely, because the first thing that the community does is reach out to the hospital. And I don't want to ever say I can't help you. And so we reached out through the telebehavior, and we were able to have sessions, virtual sessions, with other kids his age that they needed to grieve. And then inclusive of relatives of this young person, family members, friends he went to school with. It was a huge community event. And we were able to help with that using the telebehavior.
Alan, do you have any stories or any vignettes of need for this in your community there in Adams County?
You know, we didn't have, a tragedy like Rose had in her community that she mentioned to us. Again, I brought my family to this community. My wife and kids are not living in Cincinnati. They're living in rural Ohio, in rural Appalachia. I go to church with these people. I see them at the local stores. I try to keep my dollars here. I just see the heaviness in people as I walk around, and I try to engage a lot of people. It's just my personality to talk to people and encourage people, and it's just lift them up. And we just need a lot of warriors to help. Like you said earlier, give a lot of warriors the tools, these heroes, these even ministers, whatever it is, just empower people, empower civic groups, volunteer groups, give them the tools to help these people and give them a helping hand. And even this week, we've been on restriction on families or individuals going up to our acute floor, and that's been a hard year as we had the iPads and tablets and things like that so they could see family members. And only this week we are opening that up to different volunteer groups. We're happy to have some of the elderly in our community that volunteered at this hospital, the pastors that serve this community, finally have access. You know, there's some rules that we have in place and the vaccination and, you know, whatever else, but it feels like we're finding maybe a little bit of normalcy. We're finding our rhythm, finding our pace. And I'm happy to be a part of that progression. I just think if, you know, we're about on the 50-yard line, if I give a football analogy, and we need to go that extra, you know, 20, 30 yards, whatever it is, to really see what we can do. And again, I appreciate, you know, all the questions that we got today. I express my gratitude. And maybe if I didn't express my gratitude to Congressman Wenstrup, I've met him multiple times. He's been in my hospital multiple times. And when he comes, I talk about rural America and our responsibilities. He always smiles, he listens, but we give it out pretty good because we want him to take our message about these people and their mental health needs to Washington. And again, a lot of people on this call today, you know, invite us to Washington. We'll testify to these things and we'll testify about our community and what their needs are.
Thank you, Alan. That's extremely important. And we need to make sure that our advocacy is vocal about these issues. There was a question typed into the Q&A bar, and it really was the source of the data on the move to virtual. That was from John Burroughs, MD, President and CEO of the Burroughs Healthcare Consulting Network. And I heard him speak earlier this week, and he used that statistic as evidence of this transformation that's occurring right under our feet in terms of the shift, the disruptions we're seeing in healthcare right now. So I think it serves to give us all another reason for this legislation. So in the closing minute or two, I wanted to see, Nancy Ann, we're so glad to have had you join us today. Any observations or comments as we begin to wrap up?
Well, I just want to thank the two congressmen for their leadership on this, and you, and you know, please give Alan Morgan my best and the whole team there at the National Rural Health Association. Rose and Alan, we could not have more articulate spokespeople on behalf of the communities that you serve. Thank you so much. If this pandemic has shown us one thing, it's that we need access to healthcare in rural America. We need critical access hospitals to be strong. You know, it's not something that you can just plan on. It's not magic. It's hard work every day, keeping the doors open. And we know that that's a stress and a strain that you guys bear on behalf of your communities. And as Rose said, you're one hospital, Rose, but every critical access hospital I've spoken with, when they do their community needs assessment, mental health is one of the top issues in the rural communities. So if we learn one thing, it's that we need critical access hospitals. And if we've learned two things, it's that we need rural hospitals to have access to mental health services so that the people who live in those communities have some access. And as you both said, we get left out when it comes to the telehealth changes, because yes, adding an originating site at a patient's home is helpful, but that doesn't keep the dollars flowing so that Alan can run that program at his hospital. You know, that's not the way the whole thing was set up. And I mentioned at the beginning that I was running CMS when Congress passed the Balanced Budget Act, which enacted the original critical access hospital program. They understood then, and they understand now, if you heard our two congressmen who are leading on this issue, that for them to be there, you have to pay differently. You have to pay Medicare plus, basically. The resources just aren't there otherwise. So we just have to make sure people understand this with respect to these issues. And we really appreciate your leadership. And Brock, I saw you smiling when Alan said, we'll come to Washington. So be careful what you offer, Alan. I have a feeling you're going to be getting a call, you and Rose, from Brock. Hopefully the cherry blossoms will be out when you
Absolutely.
When you come. It'll be nice weather. But
we'll look forward to some sightseeing